7. God speaks. Can I start? Okay. Where was I? I think she's been associated 7 years, actually come 5 or more. Bachelor's at University of Missouri, Columbia, MD, University of Missouri, Columbia, intern in residency in pediatrics in Louisville. And if I did the math right, she's been a faculty for 12 years, for the next 12 years, is an inpatient attending at Norton and also Home of the Innocents. And anybody who's ever stepped foot in that place, that is the most amazing place. And I admire the folks that can work there. I always try to tell you something personal about our visitors. And she's heard me say this too many times, probably. My daughter, who is now just about to turn 7, got life flighted from Evansville Deaconess to Norton when she was a toddler. My wife flew with her, and I'm trying to get over there as fast as I can by car to follow up. And it was a little stressful, okay? So I finally walk in the room, and not 30 seconds later, Dr. Cordy walks in as the inpatient attending. And my heart rate just went down to actually have somebody that you know. Okay, so her topic is particularly well chosen. I heard this morning, we just went over 1,000 cases in the United States. I saw this in medical school and really haven't since. So it's an ideal topic. It's well appropriate. Dr. Cordy, take over.
Thank you, Dr. Crum. Oops, lots of cords. All right. Well, good morning, everybody. Thank you for allowing me to come speak to you guys today. Hopefully you will find this topic interesting. I know there's a lot in the news and talk about measles, and so I thought it would be a relevant topic. I know not many of us are pediatricians, but as we'll kind of go through, it's not just a pediatric disease that we need to worry about, and it's a public health concern. And so no matter what field you are in, it's important to know this information so that you can be prepared. I have, ooh, it didn't work. Let's see. The arrow's not advancing. If I click on that arrow, it'll work. Okay, I'll just do that. I have no financial disclosures. I wish, guys. So we'll start just by touching on the objectives. So what are we going to talk about today? We're going to review measles and its clinical course. We're going to talk about common viral exanthems that could maybe be confused for measles with all the various rashes that exist out there. We're going to discuss the management of a suspected and then confirmed case of measles, and then discuss strategies to minimize the spread of measles. And so we'll start with the patient case. So imagine you are in clinic or you're in the ER, and this is what comes in. You have a previously healthy 5-year-old boy who comes in with 3 days of a high-grade fever, cough, coryza, conjunctivitis. On the 2nd day of illness, the mother noticed small white lesions on the inside of the cheeks that you think are Koplik spots. There's a macular papular rash that began on the face and behind the ears. And on day 3, it spread to his trunk and his limbs. And he looks irritable and he's lethargic. You get his past medical history and he's been well, but oh, by the way, he's not vaccinated due to parental beliefs. Now, full disclosure, I asked ChatGPT to create a measles case for me, and this is what they produced. I was just curious what it would give me, and it gave me the most classic textbook, every little bit. They even named the Koplik spots for us, guys. And so I almost didn't include it. But I was genuinely laughing when I read this because it is so perfect of a case. And we all know that that's not reality. Like, how cool would it be if this is how everybody presented and they followed every rule that you ever read when you were studying? So I kept it in because it's a good refresher to kind of get us in the mindset of what measles a lot of times will come in looking like. But we all know in reality, it's not that straightforward, right? And so the differential for somebody who comes in with a fever and a rash is like astronomically long, right? I took a screenshot here from Nelson's Essentials of Pediatrics for fever and rash, and I just cut out the piece that includes macular or maculopapular rash. The list goes on and on and on if you add on all the different kinds of rashes that exist. And so even just cutting it to the maculopapular rash, you can see it's a very extensive list. And so we're not going to obviously touch on all of these today. We'll just hit on some of the more common ones that we see or we think about in our patient population. In countries such as the US, where endemic circulation of measles has been eliminated, most of the cases that we're contemplating, is it measles or is it not, are more likely going to be something from this list and less likely measles. But because measles is one of those disorders that we do not want to miss it and we want to catch it as early as possible, it's still important to really think about measles, which is why we're going to talk about that today. But let's talk about some of these other more common things you might see. So rubella, also called German measles, also called 3-days measles. All these rashes have like 5 different names just to confuse us even more. So as the name kind of implies, there are some similarities to the presentation of measles. You have a maculopapular rash, you have low-grade fever. The rash in this illness, however, is considered a much more mild rash. It's not as bright or dark. It's not as extensive. It does still start on the face and work its way down, so that can be confusing, but it is shorter in duration. It's only present typically for about 3 days, where true measles is longer. Another prominent finding you can see with rubella is lymphadenopathy, and it tends to be mostly posterior, so behind the ears or posterior or occipital, or then like posterior cervical is a prominent feature. And the fever, if they get it, is not as high. So just a more mild, quote unquote, presentation when you first see them. If you're thinking, is this rubella, is this measles? And then even trickier, up to 50% of people may be asymptomatic with a rubella infection. So they may not ever even know they contracted it. Complications with rubella are really rare, with the exception of if you get it in a fetus and then they are born with congenital rubella syndrome, which has a lot of severe complications. Another one, and this is probably one of the most common ones we would think of, especially in infants or toddlers who come in with fever and a rash history, is roseola, which is caused by HHV6. A small subset can also be caused by HHV7. And this follows a very specific, very classic course. So if you hear the history, you should instantly be able to figure out this is going to be roseola. And so they have abrupt onset of a very high fever, 104, 105, scary high numbers, sometimes associated with febrile seizures during that febrile period. And sometimes they won't seek care during this febrile period because that's the main symptom that they have. But then once they defervesce, so the fever will be there for like 3 to 5 days. And then at the time of defervescence is when the rash appears. And so a lot of times that's when they actually seek care, is when the rash comes in, they're freaked out, like, oh my goodness, what is this rash? And you looking back when you're getting your history is when you realize the time course, and it fits into that picture. The rash tends to be present for a couple of days. And unlike measles, this rash will start on the trunk and then work its way out. They can have other nonspecific symptoms like cough and congestion and GI symptoms, but overall it's a very benign course and they recover without any difficulties. So erythema infectiosum, or Fifth's disease, is the one that's caused by parvovirus B19. And so it is more common in school-age children, and the classic first presentation is that slap cheek rash. You always hear slap cheek, parvo, slap cheek, parvo. The rash actually has 3 different stages. And so the slap cheek rash is typically how it starts. And so they'll have these bright pink cheeks. You can see here's different skin tones to see what it looks like. And it'll spare that area around the nose and around the mouth. So it's really just on the cheeks. That is what happens first. And then after that, it goes on to be a truncal rash about 1 to 4 days later. And that is the maculopapular piece that maybe could be a little confusing if you're wondering about measles. And that, though, is primarily on the trunk. So it's not this progression down. It's I have slapped cheeks, now I have a trunk rash. And then the third stage of the rash is the other really classic description that we always think about, that lacy reticular rash. So that is actually what's happening as the truncal rash is fading. It's just fading with central clearing as it fades away. Outside of the rash, it's really mild prodromal symptoms, Sometimes they have a fever. They don't necessarily have to have a fever. And in general, this is also a fairly benign disease unless you have a baseline hemolytic anemia disorder like sickle cell or thalassemia, because the virus has an affinity for red blood cell progenitor cells, and so they can go into an aplastic crisis if they have that underlying disorder. Then there's good old hand, foot, and mouth. And so I know we think of this as being a pediatric disorder, but adults can absolutely get hand, foot, and mouth. And it's even more painful and worse in adults. And so this is caused by Coxsackie virus. You typically have the fever and flu-like symptoms, and then the mouth sores and the rash. And so the mouth sores typically start as red spots on the tongue and inside the mouth, and then they blister, and then that's when they become really, really painful. And so a lot of times the presenting symptom is like the kid is drooling or they're refusing to eat, and you're worried about dehydration. The rash is often on the hands and the feet, on the palms and the soles, which is a very specific rash location, because not a lot of disorders will actually have rash on the palms and soles. And this is something that's different from measles too. You don't typically get it on the palms and the soles in measles. And then though, to make it more confusing, while some may, yes, just have it classically on the hands and feet, you can also have spread. It can get on the buttocks and the legs and the arms, and it can be maculopapular before it becomes that blistery rash. And then finally, while the rest of them have been viral exanthems, I think it's really important to talk about Rocky Mountain spotted fever because it is one that you absolutely would not want to miss. And so that's the tick-borne illness caused by rickettsiae if you get bit by an infected tick. And so the classic triad for that is fever, headache, and rash. This, if you don't catch it early, can rapidly lead to death if you don't treat it. The rash is common, but it is not necessarily the first symptom. So you have that viral prodrome where they have the fever and the headache, and then the rash comes 2 to 4 days later. A lot of times they will be seeking care in that initial period before the rash because they feel so crummy. And so you really do have to have a high index of suspicion because it's hard to really diagnose it just based on the general symptoms before that rash develops. And so you're going to want to make sure and take a good history, take into consideration what time of year it is. Have they had any travel or been outside, and really try and get a good exposure history. Additionally, your labs could be supportive if you're not sure. A lot of times if they have this illness, they'll have hyponatremia and transaminitis. So you would want to get some screening labs. But then when the rash shows up, that's typically when the light bulb can go off if you haven't gotten to it at that point. The rash for here typically will start on the wrists and the ankles. So much different location than most of the other rashes we've talked about at this point. And it'll start as flat pink macules, but then it'll start spreading up the arms and onto the trunk. And this one will also get to the palms and soles. So hand, foot, and mouth and Rocky Mountain are two of the ones that actually will go on the palms and the soles of the hand. Hopefully by this point, you've caught it and started treatment. If you don't and they get to the later stages of Rocky Mountain spotted fever, the rash can become petechial later on. So that is some of the more common fever rash presentations we think of when somebody comes in with a maculopapular rash. Let's switch gears now for the remainder of the talk and talk about measles. So measles is a single-stranded enveloped RNA virus. There's only one serotype, and humans are the only natural host. There's no other reservoirs. It's just us, spreading it to us. The clinical course for this is very specific, which is helpful when we're trying to figure out the likelihood of, is it measles versus another rash? But because of the similarities is where it gets tricky. But it is the viral prodrome is first, and then you develop the rash next. And so the viral prodrome is what we talked about in that stem, right? They have fever. A lot of times it's high, 104, 105. The 3 C's, cough, coryza, conjunctivitis. We always learn the 3 C's in med school. And then Koplik spots. And so you can see here, they're a little harder to see, but there's white spots there on the buccal mucosa. So they can be white or bluish on a red base is typically what you would see for the Koplik spots. After the viral prodrome is when the rash comes, and it follows a very classic pattern. It always starts at the hairline or maybe even just inside the hairline, and will start to spread down over the face and the neck and the trunk, and then out down the arms and the legs. but will typically spare the palms and the soles. And the rash is present so longer than the German measles, which is 3 days. It's present 5 or 6 days or more. And so here's just additional pictures on different skin tones, different stages of what that maculopapular rash might look like. Initially, the rash will blanch, and eventually the red spots will coalesce together to a more uniform redness. And then you can also get peeling later on, where it will peel off in scales. When it starts to fade, it will fade in the order in which it appeared. So it will start fading at the top and then fade its way out down the bottom. From a timeline standpoint, I'm a visual person, so I had to like plot this out. So the rash appearance is considered day 0, right? And so the exposure from when they were exposed to the time of the rash presentation is on average 14 days. But the variation can be anywhere from 7 days to 21 days before they develop the rash symptom. You are contagious very specifically in the 4 days before the rash and the 4 days after the rash. Around the 4-day mark before the rash, so, oh, my arrow doesn't show up, but the 4 days before, at the beginning of that contagious period, that is when you're typically going to start to see the prodrome, the fever, the 3 Cs, the Koplik spots fits in that window, and then the rash comes. It's important to know if somebody is immunocompromised, they may not develop a rash for measles. And so that makes it much trickier. They will also shed much longer, so that contagious period is drawn out much more than that 4-day mark after the rash. With measles, common complications that we see are diarrhea and otitis media. That is present in about 1 in every 10 cases, so that's quite a bit. You can also get croup and pneumonia commonly. Unfortunately, there's also a lot of severe complications. So a lot of those viruses we talked about before are pretty benign in the grand scheme of things, but measles is not, because there's such high rate of complications. And so pneumonia can be seen in 1 in 20 cases, which is quite a bit. And then even acute encephalitis is 1 in 1,000 cases. And the scary thing about the encephalitis is that it can lead to permanent neurologic brain damage for the rest of their life if they catch it, if they develop that. And then unfortunately, there is not an insignificant death rate. So the fatality rate is 1 to 3 out of every 1,000 cases will die from measles. And it typically occurs from respiratory or neurologic complications. And pneumonia is actually the leading cause of death in young kiddos that get measles. Then to top it off, there's this really crazy, scary entity of subacute sclerosing panencephalitis, where they can have measles, they can make it through, they can recover, they can go about their normal lives, and then 7 to 10 years later, they develop this fatal neurologic degenerative disease, where they've been fine, and then all of a sudden they start having behavioral and intellectual deterioration, and then seizures, and then death. So it's definitely not a benign disease. Who is at highest risk of having the really severe complications? Infants and kids less than 5, or then anybody over 20, right? So there's only a very small window where you're less risk for these high complications. Pregnant women and immunocompromised individuals are more at risk too. So even non-pediatricians have to worry about their patient population, right, when we're thinking about measles and risk. So are you ready for measles if it showed up at your door? So the first thing we would need to decide if somebody comes in with a fever and a rash is, do I think it's measles? Do I need to worry about measles, right? And so it's important to not only get their clinical symptoms and history of what's happening in the acute illness up to this point, but you're going to want to really get detailed historical information about their recent exposure possibilities, their travel, who have they been around, and you're going to want to get their immunization history, and not just asking, are they up to date, but you would want to physically see their records to confirm that, yes, their shots are or are not up to date. And so this is actually a really, I thought, a very helpful testing algorithm that was on the CDC website. There's so much stuff on the CDC website, guys. It's actually fantastic. And this is intended to be used by bedside providers in settings where there is not local measles transmission. So this would be applicable here because we don't have measles transmission going on here. And the reason that we would use this is it assumes the pretest probability for most people that would come in is low. If you were in an area where there was an outbreak, you would not want to use this algorithm because you would have a much lower threshold to start testing people for the possibility of measles. And so we'll work through just a little bit. And I'm not one that likes to stand up and like go through all these algorithms, but I think there's important points within this algorithm and its branching points. So if we start at the starting point, you're going to consider this in somebody who's got fever and that maculopapular rash. If you have a vesicular component to your rash, that automatically boots you out of the algorithm because there's no chance that measles is going to have a vesicular component. So if all those things are met, you would go down. I wish I had it. Is there any way to get an arrow? Can I walk away? I guess I can walk away, right? So that would boot you off there, right? So say you have the fever and the appropriate rash, you would go down. And the next thing you need to determine is the risk, their epidemiologic risk, right? So you're going to ask, have they traveled internationally? Have they traveled around the country to an area that maybe there's a measles outbreak? Or have you had any known confirmed exposure to a case of measles? And the look back time is 21 days. Because if you remember back to the exposure to the time of rash, the longer end of that is 21 days. And so you need that historical information. If they have yes to any of that, you need to be worried about measles. If they don't, we need to go to the next tier level of questioning, right? And so you want to know, okay, do we have the 3 C's? If we don't have the 3 C's, then it's probably not measles. But if they do, okay, have you gotten an MMR recently? Maybe the news is scary, so you finally decided to get your shot. Well, you can have a fever and a rash that looks like measles after the shot for a brief period of time. And so if that's what is happening, then you're off the pathway because it's probably just from the shot reaction. But say you have the rash, you have the fever, you have the exposure potential, and you have the 3 C's. What's your vaccination status? That's the biggest last final question. If your shots are not up to date, absolutely you're worried about measles. But if you're vaccinated fully, then it's probably still not measles after all these things because the likelihood of catching measles when you are fully vaccinated is very uncommon. It's possible, but very rare. So in most situations, you would be more likely seeing a presentation of one of those other more common viral exanthems. So briefly, let's just talk about the spread and why it's so important to figure this out and to figure it out quickly. Because measles is crazy infectious. It is like one of the most contagious infectious diseases that exists out there. It's transmitted by direct contact with infectious droplets and then airborne spread when anybody breathes, coughs, sneezes, you name it, in a room. It can hang out in an airborne space for 2 hours. So person is in there, they have measles, they leave the room. It is still contagious in that room for the next 2 hours if you were to enter without a mask, which is crazy to me. And what does it mean to be in like a shared space with somebody with measles? So in the traditional sense, being in a smaller room with them or in a clinic waiting room counts, but you can also be in different rooms or in a larger space, but if they share the same air handling system, that is considered an exposed space. And so that would be a much more harder thing to think about from an exposure standpoint. Up to 9 out of 10 susceptible people who come into close contact with somebody with measles will develop measles. 90%. That fact to me continues to blow my mind, even though I've read it like 5 million times up to this point. It's so infectious, which is why it's so important to have a high index of suspicion when somebody comes in, because we want to minimize the spread as much as possible. So again, are you ready for measles? What are you going to do when somebody comes in? So back to that patient, that initial patient that comes in. You've gone through your algorithm, you decided that they do likely have measles. What is going to be the first thing you need to do when you are with that patient? That is going to be to isolate them because of that contagiousness factor, right? So the very first thing you're going to want to do is give them a mask to put on. If they're over 2 and they can tolerate a mask, the mask needs to go on and it needs to stay on. You then want to shuffle them away from everybody else and put them in a private room and close the door. Ideally, you would want to put them in a negative pressure room if it's available. If they're in a negative pressure room, they can take off their mask. If it is not negative pressure, they need to keep the mask on for the entirety of the time that they're in that room to minimize exposure risk. And then you want to implement airborne precautions. So the whole 9 yards with the N95s, even in fully immune caretakers, they would still need to put on the N95 to be considered properly protected. Next step would be preventing anybody who is not immune to measles from entering the room. If you have healthcare workers that are not immune, which should be rare these days because I think we have to prove it in order to work in the hospital, but any non-immune people, you would want to deny access to the room, and only those that are immunized could go in and take care of those individuals. And then the next thing you would want to do would be to notify your infection preventionist or specialist, whatever the facility or the clinic has, so that they can start working on the appropriate next steps on their end. So how long would the isolation last, right? So not everybody that get measles is admitted to the hospital. A lot of people will be at home during the course of their illness. So if they're at home, they would have to isolate at home for 4 days after that rash started, because again, it's 4 days before and 4 days after. If they're admitted to the hospital, they would need to stay in those airborne precautions for 4 days after the rash. I guess technically after that point, they could go to normal isolation, contact droplet. It's important to remember that eventually when those patients leave the hospital room, that the room is still infectious for the next 2 hours. So you would want to leave it vacant for 2 hours after they go home. And then after that point would be when you would want to go in to do disinfecting. At that point, standard cleaning techniques and disinfectant are adequate to kill the virus. So you've properly isolated your patient, you've properly protected yourself and your staff members. Now what are you going to do? So now you need to get lab confirmation that they do in fact have measles, right? And so here is a table from the CDC of different testing recommendations, and there's several options that they have. But the preferred method would be to get a nasopharyngeal or an oropharyngeal swab to send for PCR. This is important because you can do molecular analysis this way to determine the genotype, and this really helps map transmission pathways from a public health standpoint where they can link or unlink cases with this data. It's ideal to get this. Wait, sorry, guys, I clicked too many times. It's important to get this ideally in the first 3 days is when you're going to get your best sample from the rash, but you can use it up to the 10-day mark. After that 10 days, it's not the preferred method of collection. When you get this, you will also want to get serum sample to do IgM and IgG. It used to be this is how we confirm the diagnosis was with IgM, but now with PCR, we typically will use this more as an adjuvant test. It is not really good in those first 3 days because the body hasn't had the time to ramp up the immune system, but it stays positive longer than a PCR. So you can use it in that tail end if somebody is coming in. The important thing about the IgMs that's important to remember is that with that test, you can have false negatives and false positives, which is why the PCR is really the preferred test. If you get it in that early window where it's too early, you may have a false negative because they just haven't had time to ramp up their immune system. But you can also, on the flip side, have false positives because there's cross-reactivity with certain febrile illnesses like parvo, or if you have rheumatoid factor, that can give you a false positive IgM, and so it's not as reliable as that PCR. So measles is a mandatory, immediately notifiable disease. So as you're working to collect these samples, the next thing you have to do is call your local health department. So this is actually your Hopkins County Health Department phone number that I found. And I actually drove by it when I was coming to the hospital. I was like, oh, I saw that when I was looking online. So you would want to call them. They are your go-to person if you are worried about measles in any manner. They're going to help you with guidance in deciding, you know, is this patient actually somebody that probably has measles? They will help you with those conversations and that algorithm to determine if you really need to go down that pathway. They're going to help you determine where to submit the specimens and how to ship them. Most local testing for measles is not available. And so really the testing ultimately gets shipped either to the state public health labs or the CDC. And so your local health department person is the one who will help decide for you where does it actually need to go to. And then ultimately, if the patient becomes positive, it's confirmed they're going to be the ones that are helping to do contact tracing for exposures. And so it's very helpful to get them involved early. If it's after hours or for whatever reason you call that number and nobody is available, then you would want to call the Kentucky Department of Public Health epidemiologist on call. So you've isolated your patient, you're protecting yourself and your staff, you've done the testing, you've called the health department. What are you going to do for your actual patient who you're worried has measles, right? And so unfortunately, there's no specific antiviral therapy, and it's really just supportive care. So fluids are often important, especially if they're having diarrhea or to prevent insensible losses with their high fevers. The antipyretics can help with comfort and then to help with those fevers that they're having. Secondary bacterial infection. So I forgot to mention this, but in those common complications, I mentioned pneumonia. It could be a primary viral pneumonia, or it could be a secondary bacterial pneumonia. And so in those situations, you would want to treat with the appropriate antibiotics as part of your supportive care plan. And then there's vitamin A supplementation. So let's talk a little bit about vitamin A. So the WHO recommends vitamin A for all children who have measles, regardless of their country of origin. And this is because in resource-limited countries, giving vitamin A to these kiddos who have measles has been associated with decreased morbidity and mortality. Now, in the US, we don't necessarily have the degree of vitamin A deficiency that exists in resource-limited countries, but it can be seen. And then additionally, severe measles can lower our overall body vitamin A concentrations. So regardless of what country you live in, and regardless of whether or not you're being treated in the hospital or you're monitoring at home, the AAP and the Red Book recommends that you do give vitamin A supplementation in an acute measles infection. You would give it PO once daily for 2 days only. And the dose varies, you can see here, based on the age. It's important, though, to talk to your families about vitamin A and why we're using vitamin A and why we're limiting it to just those 2 doses. Vitamin A has been in the news a lot lately because of some of the stuff that's going around in the media. And so now, in addition to admissions for measles, there are some kiddos that are being admitted for vitamin A toxicity. In response to this, organizations like the AAP and healthychildren.org have been putting out memos and notifications trying to talk about how vitamin A is not, one, preventative, it's not a treatment, and that there are complications if you just give it willy-nilly, and really trying to educate the public about the proper use of vitamin A so that we can avoid the secondary complications of these vitamin A toxicity admissions. Cod liver oil, I think, is one of the things that's been promoted a lot in the media, and it actually has very, very high concentrations of both vitamin A and vitamin D, which can become problematic in children. So just so we are all aware of what vitamin A toxicity might look like, vitamin A is stored in the liver, and so you can have the general complications we often list when we're thinking of things like nausea, vomiting, headache, blurry vision, but you can also have really severe complications. It does cause intracranial hypertension, and then you can actually have liver damage and liver failure with high enough loads of vitamin A. You can have hepatomegaly, transaminitis, jaundice, fibrosis, cirrhosis. It can be really hard on the liver. If you think about isotretinoin, so the acne medication, it is actually a vitamin A analog. Anybody of childbearing age, before the dermatologist will ever prescribe it, you have to be on confirmed birth control because vitamin A is such a strong teratogen. So that's also something that's important to consider and educate individuals on, is about that potential possibility in childbearing women. So you're taking care of your patient. What about everybody else that we talked about could possibly be exposed in those waiting rooms or in, on the subway or in the McDonald's, right? The list could go on and on and on. And so first you really need to decide who's considered exposed. And so an exposure would be somebody who's not wearing the appropriate protective mask, so the N95, in that shared airspace, either at the same time as an infectious person, or if they have left, if that person enters the infectious room in the next 2 hours, that is considered an exposure. And so there's 2 types of post-exposure prophylaxis for measles that can be offered. The first is the MMR vaccine, and then the second is the immunoglobulin. And so this is a chart. There's 2 charts in the Red Book. And the Red Book is like the PEDS ID Bible of what to do in any infectious disease situation. And so it's broken down into what you would do for somebody who's not pregnant and immunocompromised, or then who is pregnant and immunocompromised. So this is the chart we would use for the majority of individuals. And so I think it's worth pointing out that if you are immune, then PEP is not needed. There's no work restrictions. If you're a healthcare provider, you would go about your daily life like nothing happened. But how do you know if you're immune, right? So that's the biggest qualifier here. So you are considered to have evidence of presumed immunity if you fit any of the following categories. If you have documented age-appropriate vaccinations, if you have lab evidence of immunity, so those IgG levels, if you have lab confirmation that you've had measles in the past, which hopefully you would know that already, or if you were born before 1957. So just as a refresher about what is considered appropriate vaccination, it varies based on your age. So if you're preschool age, as long as you get 1 dose after your first birthday, and that after 12 months is a very specific cutoff. If you got it at 11 months, it does not qualify you. It's supposed to be after 12 months. So if you have 1 dose after your first birthday, you're considered immune, or if you're school age, you need those 2 doses to be considered immune. And really the biggest caveat for a second dose in any age is it just has to be 28 days after the first dose to be considered a valid dose. If you're an adult, if you're not considered high risk, 1 dose after you turn 1 is sufficient to be considered immune. If you have high risk factors though, then you would want to be having 2 doses to be considered immune. And so what do they call high risk? Everybody in this room is considered high risk because we are healthcare providers. Additionally, anybody who is in a college dorm or like that congregate setting is considered high risk, and anybody who does any international travel is considered high risk. So those adults, travelers, healthcare workers in small, tight settings would need 2 doses to be considered officially immune. And so back to that chart, you would ideally, so everybody that's not considered immune, what would you want to do? And so you really want to try and catch them in the first 3 days from the exposure, because if you do that, then you can give them the MMR vaccine. Data suggests that if you give them the MMR within the first 3 days, that they'll have protection and it can modify the disease progression. Outside of that 3-day window, that's when you would move on to the immunoglobulin administration. Now, it's also, I think, important to point out with this post-exposure prophylaxis, what do we do scenario? Even if you give them the MMR, even if you give them the immunoglobulin, they're required to home quarantine. And to remember that home quarantine is 21 days. It's a long time to be home quarantined, but it's important because that is how long it could maybe take from an exposure before they develop that rash. Then I think it's just worth mentioning for those that are pregnant or immunocompromised, you wouldn't give the MMR vaccine in this scenario because it is a live virus. And so that is a general contraindication to MMR, no matter what the situation. So let's move on to true prevention. So that's post-exposure prevention, essentially, but true prevention. And what does that look like? And so that is where our measles vaccines come into play, right? And so there's unfortunately no single antigen measles vaccine available. We do have 2 group vaccines, so right? So MMR is the one we think about most. Then there's MMRV where it attacks on the varicella. Because of that varicella piece, it's only available to people 1 through 12. So I'm mainly going to talk about MMR because the other one's not available to most of the people that we would be treating from the group in this room. And so the CDC recommends that everybody gets 2 doses of the MMR at least 4 weeks apart. The second dose was actually added back in 1989 when they noticed there was an outbreak that was occurring in people that had gotten the first dose. And so they realized that you can have vaccine failure after just 1 dose. And they've done research and it looks like 2 to 7% can have that primary vaccine failure. So they added in the second dose in the late 80s. With the CDC 2-dose regimen, if you just give them 1 dose, it is 93% effective in preventing measles. And then if you add in that second, it's 97%, which I think is a stellar statistic. It's fabulous. It's a safe vaccine and it does such a great job. And so it's so important to promote this as the best way to prevent measles. If you get the 2-dose series, the immunity is lifelong. It protects you lifelong for measles and rubella. Now, it's a 3 disease combo. Mumps, it does wane in your immunity over time. So if you were around like a mumps outbreak later on in life, you may need an MMR booster from the mumps standpoint, but not for the measles or the rubella standpoint. And then boosters aren't necessary, and it's not even recommended that you need to check your titers. And so here's just a refresher. We all love and hate the immunization table, right? But the 2 doses for kiddos, it's recommended in 12 to 15 months and then 4 to 6 years. If you get behind or somebody comes in and they decide that they do want to now go ahead and get the MMR vaccine for their children, the only big caveat is that they do the 2 doses 4 weeks apart. Otherwise, you can time it under no other specific restrictions. Adults, Again, how many shots are recommended is based on your risk factors. And so if you are not high risk, then you get 1 dose at any time and it's sufficient. If you're high risk, so all of us, then you would want those 2 doses. If you have 1 dose and you don't have those risk factors, they don't recommend you do quote unquote catch up and get a second. You're totally fine with the 1 dose. I think it's worth just talking about that traveler category and international travelers in general, because they need special considerations. So if you have a patient that's coming to your clinic and they're like, hey, we're going to go on this trip coming up. If they're traveling anywhere where there's a measles epidemic or it's endemic in the area, your goal is to get them full immunity before they travel. And so if they have an infant that's before that 1 year where you get your first MMR, if they're 6 months to that year mark, you want to go ahead and give them a shot to give them a little boost of an immunity. Now, in the grand scheme of things, that shot doesn't count towards their overall immunity. When they come back, they would still need 1 at 12 months and still need 1 at 4 years. But you want to give them the protection before they go overseas. If you are over a year, all the way up into adulthood, your goal would be to get them 2 doses of the MMR before they depart. And as long as you're giving them 28 days apart. And so I know there's all the controversy about the MMR. I'm not going to go into any of that, but I think it is always worth talking about the true contraindications of any vaccine. And really, most of the contraindications for MMR all revolve around the fact that it's a live virus vaccine. And so anybody who has significant immunocompromise for any reason would be somebody that would be contraindicated. If you have HIV, if you are not severely immunocompromised, you are still safe to get the MMR. The other category would be pregnant women because of that live virus component. And so you would wait until after they've given birth. And then, like all vaccines, if they have a history of a severe allergic reaction, obviously you would be contraindicated. But really, in the grand scheme of things, there's not a lot of contraindications to getting the MMR vaccine. If you do have somebody that truly does fall into this category, how do you protect them since they can't get the MMR? That's when you really want to try and focus on immunizing all the close susceptible contacts in their life. And then the adverse events for MMR are also really rare. Fever and rash is actually the most common one, and so it can be mistaken for I am getting measles. It's important to let them know ahead of time that this can show up and to not be alarmed. They are not contagious if they develop a fever and a rash after the measles vaccine, so that's also important to stress to them as well. Fevers, seizures, febrile seizures can happen, but it's 1 out of every 3,000 to 4,000, so it's not the highest adverse effect. And anaphylaxis, although it can happen, isn't very common. And so I always like to throw in a little bit of graphics and statistics from the CDC because I think pictures are worth 1,000 words sometimes. And I think it's also worth talking just a little bit about the historical trajectory and story of the MMR vaccine. So the live measles vaccine was first licensed in 1963. In the decade before the vaccine was introduced, annually in the US alone, there were 500,000 reported cases of measles each year, 1,000 who had chronic disability because of that acute encephalitis, and 500 deaths per year. This is from confirmed reported cases. They're suspecting that the actual number of cases that weren't reported could have been up in the millions. And so you can kind of extrapolate based on that what the complication rate might have actually been. So then you can see the nice drop after the MMR was introduced. You still have the little outbreaks you can see with the peaks. The next box is 1989. So that was that outbreak that occurred where they were like, oh, wait, people are still getting it even though they've had 1 vaccine. So they introduced the second dose. And after that, flattens out. After we introduced the second dose, the US was able to declare it eliminated in just 11 years. And since that time, we have been considered a measles eliminated country. Now we're still getting cases and outbreaks clearly because that's what's happening now, but it's not from endemic circulation. It's from outside in. And so most of the cases that are occurring are from importation from unvaccinated Americans traveling abroad and catching it abroad and then bringing it back, and then it's spreading in under-immunized communities. And so there has obviously been an increase in measles cases recently, both in the US and across the world, right? And so why is this happening? Well, partly it's happening because in the US, our coverage of vaccination rates is declining in recent years. So the CDC keeps statistics on the kindergarten coverage of the required state vaccines. And so in 2019 to 2020 year, the coverage rate was 95%. Then in 23 to 24, it dropped to less than 93%. In the state of Kentucky, we are at 90%. Why are these numbers important to know? Greater than 95% is the target goal because that's when you can achieve herd immunity. So we have been below herd immunity status since at least 2019. And so with this 23-24 academic year, with that number being less than 93%, that means at least 280,000 kindergartners are unprotected from potentially contracting measles. This is just a map visual version of these numbers, and you can see the breakdown based on states. And so we are in that light orange because we are at that 90% mark. The blue is the goal. The blue is greater than 95%, and you can see not a lot of states have it, unfortunately. Additionally, besides the increase we're seeing here because of the decrease in vaccinations, there is an increase globally of measles for multiple reasons, but that just means there's more chances for Americans who are traveling abroad to also catch it and bring it back. So it's kind of a double whammy. Here is what Dr. Crump alluded to, that we hit 1,000. So the CDC tracks the data of all the cases, and then they update the data every Friday. So this is from last Thursday. It's the most up to date. And then tomorrow they're going to release another update of the statistics. And so these are confirmed cases, not including any probable cases that are under investigation. So as of May 8th of 2025, for just this calendar year, we have 1,001 cases. I thought it was really interesting to look at the age breakdown here because we think of it as being a pediatric disorder, but you have 31% that are over 20 that are part of this case group. And really, it's oddly evenly distributed for the most part between all three different age breakdowns. The majority of them are either unvaccinated or have unknown status, and only 2% had that true 2 MMR dose failure for any reason. Out of the 1,001 that were confirmed to be cases, 13% were hospitalized, with the majority being in that under 5-year age range, which is not necessarily surprising. And then so far in 2025, we've had 3 confirmed deaths, unfortunately. These are the first measles-related deaths in the US since 2015. So in the last 10 years, we have now brought it back and had several deaths. This is just a pictorial representation of those numbers. And so the darker the blue, the more the cases. And so we all know about the outbreaks in Texas. But you can see here, Kentucky is light blue, which means we've had a case. And so back in February, there was an adult internationally that ended up bringing it back in Frankfurt. This case was the first case we've had in Kentucky since February of 2023. And so I'm showing you these things just to kind of bring home the point about, even though measles is not something that is nearly as common as all those other viral exanthems that we talked about, the odds of us seeing a case of measles is increasing, and it's not in some distant state or in some distant land. We've had cases in the state of Kentucky. And so it's important to be able to recognize it and to know what to do. It's harder when things are not common to know what to do because we just don't have the practice. But it's so important to know the right steps to take to try and minimize the spread of a disease that can be potentially fatal for some individuals. And so this is more just my final slide, looking at kind of where we've been recently and now where we're at. And it's really scary statistics. The peak was of 114 cases were reported the week of March 30th, 2025. There's been reports in 31 jurisdictions, so Kentucky is included in that. And just to put it in context, so far in 2025, we're in the very beginning of May. We've had 14 outbreaks, which is considered 3 or more related cases. So there's been 14 outbreaks so far. In all of 2024, we had 16 outbreaks. So we're on a really bad trajectory to have this just continue to go up and to go up. And so circling back to the objectives, I hope you feel that we met them. We reviewed measles and clinical course. We talked about some of those more common viral exanthems that we will more likely see than measles, sometimes can be hard to tease it out, and you don't want to miss the case that actually is measles. We discussed what you would want to do if you're worried somebody has measles, right? So you isolate them, notify the right people, get the right testing, and then treat them with their supportive care. And then we talked about strategies to minimize the spread with the post-exposure prophylaxis, and then really promoting the MMR vaccine. I'd just like to say that if you are so inclined, you should really go look at the CDC website. They have so many resources, not only from a physician standpoint, but also to try and educate the public, to educate your patients. If you have a clinic space that you want to hang out information in, it's got all sorts of infographics. And so it's a very good resource to utilize. And so here are my references. I was everywhere in that CDC website. So I just wrote that as one general reference. And that's all I have, guys. Questions?
Hi, thank you for coming. My name is Cody. I'm one of the government vice presidents. I was very surprised to see that while Kentucky was sitting at 90% vaccination, Tennessee and Mississippi were greater than 95%. Do you know if they're doing anything different in terms of law or policy that's leading to them being so successful in their vaccination?
That is a question that I do not unfortunately know the answer to. It's very interesting to see the difference just in our neighbors. I know. Yeah. Yeah. I think it has to do with natural immunity. Oh, yeah, sorry. So his question was about determining if you are immune, and the last bullet point was about being born before 1957. And I think that had to do with more natural immunity because it was so prevalent and circulating within the community. Now, there was a caveat, and I didn't bring this up, but in that population, if you are still a working physician, you are recommended to have the 2-dose series. Any other questions? Yes, Dr. Crump.
Exactly.
Oh, thank you. Oh, no.
Sam, mother tells me the vaccine's dangerous. What layperson words do
You see the look I'm giving you? For the online audience, this question was about how do you have discussions with families where the mom is very hesitant to give their child the MMR vaccine. And so the shorter version is there's no simple way. And a lot of it has to go back to your relationship with the family and where you are in that established conversation, and really working through shared decision making. There's a lot of information actually on the CDC about how to have those conversations, stuff that you can give for them to take back and maybe read on their own time so that they can think about additional questions that they want to ask. I think every encounter would be different, and the words that you use would be different. I think, trying to keep emotion out of it is very important, and sticking to the facts that we know and stressing, the importance of, or stressing the safety of it, and depending on the medical literacy of the individual would determine how much you got into the weeds of things like statistics and not. And, fully expecting that you're probably not going to change somebody's mind on one encounter. And so that's one where it would definitely have to be more of a back and forth and multiple visits to try and see if you can make any headway. But to not take it like as a personal affront or decide you're just done having the conversation, because it's worth, if you can eventually convert them, it's worth it, and it's worth the effort, and it's worth trying to get the buy-in and the time that it takes to get the buy-in. Is that helpful? I can't see the chat, so I don't know if there's any questions in the chat. No, okay. Anything else? Thanks, guys.